Hello doctors, in today's video let's discuss the differential diagnosis of a non-healing wound in lower limb. So a non-healing wound in lower limb, it can be an ulcer. A non-healing ulcer, chronic ulcer. So if a patient presented with a non-healing ulcer or wound which is a chronic in nature in the OPD, then what can be the differential diagnosis for this patient? Let's discuss one by one. So in ulcer there are different type of ulcer, non-healing ulcer. So first of all, it can be a traumatic ulcer. Patient give history of trauma which is super added by the infections, and infections are responsible for poor healing, so it can form a non-healing ulcer. So one cause can be trauma superadded by infection. So this is the first cause. Second, there can be arterial cause. Arterial cause means there is obstruction in the blood vessel or artery supplying that area, which leads to ischemia. And ischemia is a potential factor for poor healing and it leads to ulceration. And this condition is known as peripheral arterial disease or peripheral vascular disease. So second cause can be arterial ulcer due to ischemia. The third cause can be a venous ulcer. In venous ulcer, what happens? There is dilatations of veins and there is blood pooling in the veins, and which leads to decrease in cardiac output, decrease in oxygenation of blood in lungs, and finally due to the stagnation of blood here there will be less oxygen supply, leads to hypoxia and formation of ulcer. This is venous ulcer. So this is the third cause. Fourth cause can be if the nerve supply surrounding a tissue, the nerves supplying a tissue, they are not working due to nerve injury or some other cause like in diabetes mellitus, due to the neuropathy. Due to the neuropathy and nerve involvement, the sensation of the particular tissue lost, the sensation are absent, and due to repeated trauma, and the patient is unaware of this repeated trauma, which leads to formation of ulcer at that place due to the loss of sensation. So these type of ulcers are neurotrophic ulcers. So this is the neurotrophic ulcers, the fourth one. In metabolic disorders like diabetes mellitus and joint disease, rheumatoid arthritis, gout or anemia, these four diseases can cause ulcers. In diabetes mellitus there is three mechanisms of causing ulcer. The first one, peripheral neuropathy, which cause neurotrophic ulcers. The second one, microangiopathy, which cause ischemia and finally cause ulcers. And the third cause is the high blood sugar, which attracts bacteria, and due to the inflammation there is more chance of non-healing wound formation. So these are the three mechanisms in diabetes mellitus which cause ulcers. And this is the fifth one. The sixth one cause is malignancy. Due to the long-standing ulcer which is non-healing, the patient can present with malignant changes in the ulcer, like in long-standing venous ulcer, the ulcer convert into the squamous cell carcinoma, which is known as Marjolin ulcer. So there can be malignant changes in the ulcer in long-standing non-healing ulcers. So this can be the sixth cause. And the seventh will be vasculitis. Due to the inflammation of blood vessel wall, there is formation of ulcers in autoimmune disease like vasculitis, which forms ulcer, and I have already told about the infection. There is trauma. Trauma will lead to the infections and the wound become non-healing finally. So these are the major causes you should keep in your mind when you see a patient presented in OPD with non-healing wound. First will be traumatic, superadded by infection. Second one, arterial ulcer. Third one, venous ulcer. Fourth one, neuropathic or nerve injury due to nerve injury. Trophic ulcer. Fifth one, due to the metabolic disorders like diabetes mellitus, rheumatoid arthritis, gout anemia. Sixth one can be malignant changes in the old ulcer. Seventh one due to the vasculitis, and eighth one due to the infections. So these are the eighth cause of non-healing ulcer, and we are going to discuss in detail one by one in the upcoming slides. So first of all, we are going to discuss about this type of ulcer which present in lower limb here around the medial malleolus, and this area, if you know, this area has a name which is known as Gator's area. So there is ulcer in Gator area, first thing. Second one, there can you see there is skin changes like this. There is redness which is known erythema, and there is white, and there is skin changes, thickening of skin which is known as lipodermatosclerosis, erythema, and there is hemosiderosis, this brown pigment heme known as hemosiderosis, and there is a ulcer. You can see here there is a ulcer here which has sloping edges. So for your information I can elaborate here. Ulcer has 5 parts: the skin and the ulcer, this junction where the normal skin and ulcer present, this is known as margin, and this wall of ulcer is known as edge, where this is floor you can see, and this is the base on which ulcer sits, like it can be a bone, muscle. So you can palpate base and see floor. So these are the parts of ulcer, and here the edges of ulcer will be sloping like this sloping edges, and this is mainly associated with deep vein thrombosis or varicose vein. So beside the ulcer examination, you have to assess both the limbs for any varicosities, any varicose vein. So these ulcers are mainly painless, or patient can present with mild pain. There can be skin changes. I already have discussed the skin changes, and it is associated with DVT or varicose vein, mainly in the Gator's area, and the ulcer has sloping edges. By these 5 points, you can think of a venous ulcer. So these are the points you can see for a venous ulcer. The second one, though, then the first one is, this is the venous ulcer, venous. And in second case, let's assume there is a case which present with ulcer at the dorsum of foot, and in distal area, like here. In venous ulcer mainly occur here at medial malleolus, but if patient present with ulcer at the distal end of foot, then you can think of a ulcer which is known as arterial ulcer. Arterial ulcer like this on the finger, in the web spaces here or foot, and there is a, you can see here, gangrenous changes. So the ulcer will be present on the dorsum of foot, and it is painful, extremely painful, due to the ischemia. There is accumulation of substance P in the tissue which irritates the nerves and which lead to the pain. So the arterial ulcer are located distal and dorsum of foot. They are painful, and after this, if you suspect the arterial ulcer, you have to examine all the arteries, peripheral arteries, for pulses. Like in foot, you have to look for dorsal pedis artery, anterior tibial, posterior tibial, popliteal, then femoral, radial, ulnar. You have to examine all these arteries. I will form a new video for the examination of these arteries, where these arteries located. So if you suspect a arterial ulcer, then you have to examine all the peripheral pulses. And these type of ulcers are associated with rest pain. The patient complain of pain in legs or proximal limb even at rest, and there can be gangrene of fingers or toes, and the rest pain mainly of burning type. This is the characteristic of this pain. So these are the things you have to keep in mind for an arterial ulcer. So after the venous ulcer, we have completed arterial ulcer. Now we are moving to third type of ulcer, where you can see this type of ulcer. Like this type, you have punched out the tissue. Punched out means the edges of this ulcer lie perpendicular to floor of ulcer. So the edges are perpendicular to floor. But in venous ulcer, the edges were sloping like this, but here they are like this. So these are perpendicular. So they mainly present at dependent parts, like here at the heel, foot, it can be at sacrum as a bed sore. So these type of ulcer mainly present at the dependent part. And if you check the skin sensation surrounding to ulcer here like this, if you check the skin sensation, they can be absent in a neurotrophic ulcer. So this type of ulcer are punched out, and these type of ulcers are known as neurotrophic ulcer due to the loss of sensation, which can be secondary to diabetes mellitus or any nerve injury. So these type of ulcers are known as neurotrophic ulcer. So you have to check sensation of surrounding skin in this case. Next one, the fourth one, this type of ulcer. Here you can see the edges of ulcers are moving outward like this, raised above. So these are known as everted edges. And here you can see the ulcer is highly vascular. If you touch this type of ulcer, minor trauma can lead to bleeding. So it is known as bleeding on touch plus everted margins. Then you can suspect a malignant ulcer. So here you can suspect a malignant ulcer if a patient present with everted margins and an ulcer which bleeds on touch. So long-standing non-healing ulcer with everted margins and patient ulcers bleed on touch, then you can suspect a malignant ulcer. It can be a squamous cell carcinoma. So this is the malignant type. Here you can see multiple petechiae hemorrhage in both the legs, bilateral involvement. There is ecchymosis and petechial hemorrhage. So here you can suspect a autoimmune disorder like vasculitis. So this type of picture can represent a ulcer secondary to vasculitis. Now we are going to mention the last ulcer. Here you can see, if a patient gives a history of recent trauma, then this type of ulcer can be seen, which is known as, I already discussed, traumatic ulcers. Traumatic ulcers can be due to mechanical trauma, like hitting by any object, and it can be physical due to the radiation exposure, and it can be a chemical due to the chemical hazardous. These things can lead to the traumatic ulcer. So this type of ulcer is known as traumatic ulcer. So there can be history of trauma, radiation, chemical exposure, which is superadded by the infection and converted into the non-healing ulcer. So these are the differential diagnosis for a non-healing wound of lower limb. So how to confirm the diagnosis? We have some tests to diagnose These type of ulcers, let's discuss one by one. First of all, you have to send all routine. CBC, in CBC you can look for WBC count. If raised, there will be infection, and HB if decreased, there can be anemia which can cause ulcer. In LFT, KFT you can send, and if the total protein albumins are decreased, then you can think that liver is not working and the patient is malnourished. Due to malnourishment, there can be ulcer formation, and you have to send HbA1c or RBS to rule out diabetic ulcers. You can do Doppler USG of lower limb to rule out any DVT or arterial ulcer or venous ulcer. So these are the things you can rule out by a Doppler USG, arterial plus venous. For arterial, you can go for CT angiography also to look for level of obstruction of a particular artery. So with clinical examination of pulses, you can order a CT angiography to look for the specific level of obstruction. ANA, anti-nuclear antibody, you can send this test for any autoimmune disorder like vasculitis, etc. And you can send a swab from the floor of ulcer. You take a swab from the floor of ulcer and send it for culture, and you can identify the specific bacteria which is growing at the floor and causing non-healing of ulcer. So you can send a swab and a wedge biopsy. Like if this is the ulcer, you can send a triangular shaped biopsy from the edge like this, but you should prefer this type of biopsy in which the normal tissue can be taken and the part of ulcer can be taken to compare. The wedge biopsy should be sent for malignancy. When you suspect a ulcer is malignant, then you can send wedge biopsy to confirm the diagnosis. So these are the clinical approach and the investigations you should do in a case of non-healing ulcer of lower limb. So by the clinical knowledge and with the help of investigations, you can accurately diagnose a case and know the etiology behind the non-healing of particular ulcer. So this is all about the approach to a lower limb non-healing wound. I hope you enjoy this video and it will help you in next OPD. So keep learning and keep going. Thank you for your attention.